Hi, hello everyone. We are now starting the webinar of the monthly webinars of International League Against Epilepsy. This time, I think it is conjoint one between East Mediterranean region and Africa Commission. There are two lectures. The first lecture will be presented by Professor Mohammed Jan. He is a professor of pediatric neurology, and he is at the same time consultant of clinical neurophysiology, Department of Pediatrics, Faculty of Medicine in King Abdulaziz University Hospital in Jeddah, in Kingdom of Saudi Arabia. The lecture will be epilepsy stigma in the East Mediterranean region. So please, Dr. Mohammed.
Bismillahirrahmanirrahim. Thank you very much. Dr. Jandil. I'm really delighted to be with you tonight and look forward to hearing also the other presentation. Let me just start sharing my screen. So what I'll try to cover with you over the next 40 minutes or so is some data from our region on epilepsy stigma. Studies that we have conducted in our area and review some of the relevant literature in the neighboring countries in the Eastern Mediterranean region. I come from Saudi Arabia, from Jeddah. You see it there in the map. If for those who are not familiar with this region, this is our university hospital. Stigma, when you talk about stigma really is a phenomenon where an individual with a certain attribute is deeply discredited by his or her society or rejected as a result of that attribute. So stigma is a process by which the reaction of others spoil normal identity of the person. So it's stigma is a distinguishing mark of social disgrace. It's really a universal concept. So it's not peculiar to our region or to the Arab countries. It's really universal across even different cultures. It is broad and variable depending on a given history, social norms, language, and of course, it is taken into the context of the culture. When you look at the stigmatization model, there are kind of different levels or important aspects, starting with differentiating the person or labeling him or her from peers, then linking that affected person to certain stereotypes that generalizes issues that are seen in some people to every person. And then the concept of separating one from the others, so us from them, and subsequent disadvantages that that follow. Important terms, before I go through the various studies from our area, important concepts, I have them highlighted in this slide. So social identity, stereotype, prejudice, discrimination, social disability. So a given label resulting in a spoiled social identity based on an inaccurate or simplistic generalizations is a stereotype. Unfair judgment and unreasonable attitudes toward an undesired difference. Then discredit or reject the stigmatized person from the society, and subsequently impose some social restrictions resulting in the so-called social disability. So there are different levels or depth of the stigmatization model. In the center, where one self-perceive the courtesy of stigma, and around it is really the illness, the stereotype, perceptions, and outermost is the social stigma. When you talk specifically about stigma, there are kind of different types of stigma. So stigma itself can be enacted, where there is an actual episode of discrimination, or can be self-perceived or internalized, can be explicit, where there is a deliberate process resulting in stigmatization, or implicit by reflexive or associative response, courtesy related to someone with stigma. I borrowed this slide from my colleague, Dr. Haytham Tayyib, who has a really nice review of the topic. And you see where the society, the culture, the religious aspects play part, resulting in stigma. And then there are factors that can limit or speed up this problem, including social values, legislation, and public awareness. And of course, stigma subsequently will affect the quality of life, and there are many other associated psychosocial disadvantages. Of course, when you read the history, when you go through the history, there are more extreme examples. And I think some of these extreme examples still exist in certain parts of the world, including banning some of these people from schools, banning them from sports, barring them from marriages, or denying certain employment. So now I'm going to present to you some of the epilepsy stigma data from our country. I'm not sure if my voice is clear and everybody can follow.
Yes, it's very clear, yes.
Great. This is a short list of the studies that I will highlight, and they are by no means inclusive of every study in our region, but I thought they show they shed light on the issue from different angles. First, the public, then as the child is young, teachers in schools, and then parents, two aspects, parents in general, and then parents during acute seizures or in emergencies. And these are studies that I was personally involved with. So the first study was done with one of my colleagues, Dr. Usama Mudaffar, when he was in training. He's now an epileptologist practicing in Jeddah. And looking at public awareness and attitudes toward epilepsy in Saudi Arabia. And Dr. Usama was able to show some evidence that at the time of the study, there was some evidence that the public awareness and attitudes is improving. We know in our culture and in Saudi Arabia and many other neighboring countries, epilepsy is linked to evil and evil spirits or demons. And this has been really from the old days, since Hippocrates. Many people still believe in that in our region. So there are different terms, maybe in Arabic, some people call it bad eyes, so somebody giving somebody kind of misfortune by looking at him or her, resulting in such an illness, or possession by evil spirits or demons or shaitan or Satan. It has been our practice, and it's really reported in our region, that many patients seek complementary and alternative therapies before they come and seek our advice. So many times, if not all the time, we are actually providing second opinion after the patient is being seen by sheikh and religious scholar and so on. We know also that attitudes are significantly influenced by the depth of knowledge of a given family or person. And we know that misinformation from unreliable sources will lead to negative attitudes in the public. So this was kind of the background of our study at that time. Our objectives were to examine the public awareness and attitudes toward epilepsy, compare our findings to the other studies from Saudi Arabia and the neighboring countries. So we used a simple 10-item questionnaire because this study was conducted on a relatively large scale to the public, so it had to be quick, which was formulated based on the available published literature. Participants were identified randomly in shopping malls and university campuses. So in general, they were generally a younger kind of population. The study was explained in person and confidentiality was assured. This was the 10-item focused questions. You see them there. Looking at knowledge, source of knowledge, if they had any personal encounter with people with epilepsy, if they have witnessed seizures, what do they think the cause of seizures, and so on. You see the other questions there on the slide. So the results, we interviewed more than 700 people, kind of 50-50 male, female. You see there 67% were less than 30 years of age. So this was a relatively young population. And 2/3 had university degrees. Although many people said that they have prior knowledge, so about 77%, still 15% linked epilepsy to evil possession. And about 1/3 preferred or thought that spiritual rituals and religious healing is preferred to medical treatment. This kind of correlated to their educational level. And about 2/3 said that they would accept patients with epilepsy in regular jobs. However, 71% had reservations on being engaged or being married to someone with epilepsy. This was statistically significant for males. It was more common in males than females. When we looked at the literature, there is a reference there on the screen. In some studies, it was reported 40% actually linking epilepsy to evil possession. And our numbers is similar to some recent studies from United Arab Emirates and Kuwait. You see the numbers there. However, it's still concerning that many people think that spiritual rituals and religious healing is the way to go. And again, we showed that we were able to find that those with good knowledge were less likely to have negative attitudes toward patients with epilepsy. So we concluded from the first study that the awareness and attitudes of Saudi public toward epilepsy is showing some improvement, but we still had problems linking it to evil possession by some, and spiritual rituals and religious healing is still believed to be effective in the treatment. So we hope that our study would provided some areas that can be targeted by focused education and public educational campaigns. The second study I'm going to go over is looking at the teachers. And this study, we examined actually primary school teachers for a specific reason. Kind of similar idea, but targeting different population of study subjects. We know that school is critical for psychosocial development, and the experience in school really impact the quality of life and future adult roles of these young souls. So risks of learning difficulties, mental health problems, and social isolation has been reported in patients with epilepsy. So teachers' knowledge and attitudes can have significant impact on students' performance, social skills, and future employment. So we were really interested to look at the teachers of primary schools and see what they thought about this problem. To study their attitudes toward epilepsy, identify areas where future teacher training and educations are required and utilized, and identify contributing factors to inadequate knowledge and negative attitudes. So we used a stratified random sample survey that included primary school teachers in the Jeddah region. And for you who do not know, Jeddah is a very large city, more than 4 million inhabitants. It has a kind of a peculiar school system where there is private and public schools, and there are schools for males and schools for females. And the city, just like any other big city, it has different neighborhoods depending on the socio-economic level of the people living. So we kind of took samples from all regions, north, center, south, west, southeast of Jeddah. We used a more detailed questionnaire that included demographics, knowledge, attitudes, and experiences of these teachers. We were able to collect more than 600 samples. Public schools, 58%, private schools, about 40%. This is the ages of the included teachers, mean of 36 years, 50-50 kind of male, female. And about 2/3 had university degrees. Although they were primary school teachers, about 66% had university degree. Many years of experience. Most teachers had a mean of 13.5 years. And again, across all the studies that we have done, education of the person predicted better knowledge. And this was the case in this study. This is the Likert scale item examining the level of teachers' knowledge. Only 17% felt that they were very well informed about epilepsy. Big chunk really had little information about it. These are some of the key results about teacher knowledge. Many thought that epilepsy is a lifelong disorder. 27% felt that one of the causes is spirit possession, evil spirit. 25% thought that the intelligence of epileptic children is below average. Evil eye is a cause in 22%, and 21% thought that epilepsy cannot be cured. When we looked at their attitudes, children with epilepsy had abnormal behavior in class. About 50% of teachers felt that way, so they had kind of negative attitudes toward them. They thought that they had future career limitations. 28% thought that they should be placed in a special class or a special school. And 25% declared that they really mind having a child with epilepsy in their class. 18% thought that they should not participate in sport activity. Again, when we look at these findings, we found them really similar to many international studies. In general, most teachers do not feel confident regarding their knowledge and consider their knowledge inadequate, and this has been documented in different countries. Knowledge was again shown that it is most important factor influencing their attitude. In other studies here by Dr. Tahir Ubaid and others, position was found 40% of the impressions. 14% in some studies thought that it is infectious or it's a mental illness in 8%. So again, more or less very similar conclusions. Primary school teachers' knowledge need improvements. Attitudes correlated with their knowledge. There need to be a focused education and training for these teachers because of the potential future implications on the lives of these young children. Epilepsy resources should be made available to teachers in school or outside school. The third study that I'm going to go over is also done in Saudi Arabia, is on parents' knowledge and attitudes toward children with epilepsy. And this study was conducted by a group of my medical students a few years ago, looking at parents in general, their attitudes, their attitudes toward these children. We know in general, parents' attitudes are significantly influenced by the depth of their knowledge, and I think studies have shown that repeatedly. It is important that parents do not overprotect these children, which is a kind of tendency with anybody with a child with a chronic problem, because this correlates with problems with adaptation, not only for the child, but for the whole family. There is also studies by Camfields from Halifax that knowledge in epilepsy, better knowledge is associated with lowered parental anxiety. And anxiety by itself correlates with the quality of life of these families. So we wanted to study parents' level of knowledge and attitudes toward epilepsy, identify correlating and contributing factors to their negative attitudes. We use the cross-sectional consecutive parents coming to the outpatient department clinics. We use the structured 40-item questionnaire, again looking at the demographics, knowledge, and attitude of these parents. One of the study authors individually assisted these parents because of language issues and issues related to terminology. And of course, participation was voluntary, and they filled an informed consent agreeing to participate in the study. 117 parents were interviewed, mostly mothers. There were fathers, but mostly mothers. their child age ranged between 1 to 16. And again and again, parents with higher education were less likely to treat their child differently. However, 29% of parents of children with epilepsy used non-medical treatments. Those who used non-medical treatments, so religious or traditional herbs or therapies, were more likely to believe that epilepsy is a mental disease or correlated in their minds with evil. These are key questions on parents' knowledge. Did you know about epilepsy before your child is diagnosed? Many said yes. Are there non-medical treatments? Many thought there is. Epilepsy is a mental disease. 48% thought epilepsy is a mental disease. And 44% thought that epilepsy correlates with evil. 38% thought the child's intelligence will be affected. And only 9% thought epilepsy can be cured. When we looked at their attitudes, although many of them thought the child with epilepsy could achieve a lot in the future, they said that they would treat their child differently. They really explored that by saying that they would avoid upsetting the child, 53%. They would treat the child different from his brothers, 44%. And they would avoid punishing the child, 34%. Other authors have reported parental doubts about their child, cognitive potential, child with epilepsy. In studies by the Campfields, they found that parents felt that children with epilepsy are not as bright as normal children. And of course, many of these misconceptions have significant negative implications, not only on the child and the family, but also on the medical management of these patients. So we concluded that the level of knowledge among parents needs improvement. There are many misconceptions, negative attitudes, and many poor parenting practices, which may explain some of the behavioral problems that these children have, behavioral, social in the future. And of course, it correlated with their educational levels. Community education is essential to improve the quality of life of the whole family. So the last study that I will go over with you today is looking at the maternal knowledge and behavior during acute seizures. And this study again was done by one of our fellows who's now a consultant, Dr. Nawal Asiri, consultant epileptologist. And we did that because we know that seizures are kind of the most common pediatric neurological emergency. So adequate education is important for proper identification, intervention, and management. And a lot of that, it depends on the parents, who are the kind of the first line people who would manage these acute or long seizures. Parents' behavior during an acute seizure is influenced by their knowledge and experience. So we wanted to study maternal knowledge of and behavior during acute seizures, identify correlating and contributing factors to their negative behavior and actions. So this was a cross-sectional study involving consecutive mothers attending outpatient department of King Abdulaziz University Hospital. We used a structured 30-item questionnaire, again, looking at their demographics, knowledge of and behavior during acute seizures. 4-point Likert scale item to examine the degree of knowledge and need for more information was also obtained. Overall, we interviewed 92 mothers. 41% witnessed at least one prolonged acute seizure longer than 10 minutes. So these parents were kind of experienced, and the reason is King Abdulaziz University Hospital is a kind of a tertiary care hospital. So many patients with epilepsy, they have difficult epilepsy. They're not your usual kind of easy patients. They're more difficult. 26 of them felt that they were not knowledgeable at all about epilepsy, despite all this experience. Higher educational level of the mother correlated with better knowledge. Only 10% of mothers were aware that there is an anti-seizure drug that can be used at home for acute seizures. And 93% thought they need more information, mostly younger mothers. This table summarizes the most important questions on acute seizure management that we looked at. You see there about 1/3 of our sample thought that the mother will take the child to the emergency room every time the child had a seizure, even if it stops quickly. Mothers said that they will keep the child mouth open with fingers or any other objects to prevent tongue biting, or they would sprinkle or splash the child with water to wake him up during seizure, 1/3. 24% said that they would keep the child on the back, and we all know it should be the side. 20% they will try to restrain the child firmly to help stop the seizure. And we know also that this behavior correlates with the joint dislocation, so it's strongly discouraged. And 17% said that they would shake the child to help him or her gain consciousness. And we know that this behavior is also very dangerous, especially in infants, because of their heavy head and loss of voluntary control, so it can result in significant injuries to the spine. Only a small percentage of mothers said that they would give an extra dose of oral medication during acute seizures. This is the Likert scale item examining the need for more information by the mothers. So 66% strongly thought they need more information. So I think this area is important to focus in our educational campaigns. So what to do in acute situation. It seems that there is more work that needs to be done in this area. Other authors have found similar associations. There is a distinguished speaker with us today on this webinar from Africa, and there are African studies that showed that in some regions of Africa, they do even really more strange maneuvers during acute seizures, thinking that these maneuvers would stop the seizures. Not only ineffective, but potentially harmful interventions. Maybe the distinguished speaker can elaborate on that during her talk. So there is need for more information, highlights their weak knowledge. I borrowed this slide from Dr. Haytham, highlighting the point that I mentioned earlier, that many people seek spiritual and religious opinions before they come to us. And part of that is the religion of Islam, where we all believe in jinn, and there is a whole surah in our holy book about jinn, with supernatural entities, and there are verses in Quran saying that some of these motor phenomena, it's like someone who's possessed with demon. But we believe in that, but this is really the exception. This is not the rule. These situations are very unusual, very rare, but unfortunately still people seek various interventions. There is, just to educate some of you who may not know a lot of aspects of our religion, but in general, there are 5 treatments that people with Muslims, they believe in it because there is evidence in the Holy Book or from Prophet verses. One of them is the so-called ruqya. And ruqya is using verses from the Quran to heal or treat patients. I encourage my patients to use Quran and readings from the Holy Book. However, I discourage that they go to some of these healer providers. Some of them use unusual maneuvers. They give treatments, waters, and oils that we do not know the source or the components of it. So it is really discouraged. So in general, in our culture and religion, we encourage using the Quran as treatment, readings from the Quran. When patients ask me, I also encourage them to drink the holy water Zamzam. And older children can take honey because there is evidence in Quran that honey helps. So all this, of course, in conjunction with our medical workup, investigations, and treatment. So there is no kind of contradiction between the two, because anyway, they do it anyway. So I try to guide them and warn them from kind of more extreme behaviors. This was highlighted in the public media recently with an article also stressing some of these points to the public. For those of you who are interested to read more about epilepsy stigma in our region, I would encourage you to read this article by Dr. Haytham Tayyib, who's really a talented epileptologist in our region. And it has a lot of philosophical kind of points and things that can stimulate your brain. So to conclude, knowledge still needs improvements. Epilepsy, no matter what we do, is still linked to evil possession. Non-medical treatments are very commonly used. Attitudes toward epilepsy correlates with knowledge. So the better knowledge, the less negative attitudes. Educational campaigns really should be encouraged. Thank you very much.
Thank you very much, Dr. Muhammad, for this nice presentation. Really, it is a very good, informative, and you demonstrate a lot of research which is very practical and useful. Well, now we will shift to the question and answers, and we are waiting for any question from our audience. Well, meanwhile, I will start myself with one question about, the stigma, as you know, is, and as you said, it is not an Arabic problem. It is in different cultures in Africa, Asia, Middle East, even South America, and even in the developed countries. So this is a fact. Well, we have, to discuss or to go through the ways of reducing this stigma or trying to reduce the stigma and the best ways, whether it is education or one of the suggestions to reduce this stigma in the Arabic region, at least, is the choice of changing the name of epilepsy, as-sara'. This problem is being discussed in more than one country in Arabic region, and they believe that if we change the word as-sara', epilepsy, into something like اضطراب في كهربائية الدماغ or derangement of electrical brain activity, this they believe that it will reduce the stigma or reduce the impact on the social aspect. Do you believe? I want your opinion, and I will tell you about my opinion later.
Yeah, I actually strongly agree. I strongly agree with that. Actually, in my clinic, I try my best to avoid using the term epilepsy with patients. So I try to explain to them what it is. I would use the term seizures or electrical disturbances or cortical disorder, various terms in Arabic, which kind of more or less mean the same. So I would say تشنجات متكررة, اضطراب كهربائي. However, many people at the end, they say, well, doctor, but do you think the child has epilepsy? And of course, at that stage, I have to tell them. But I stress that the term will not add anything to what I have already explained and elaborated on. It's just a kind of a label. So putting the label will not help anything. Understanding will help. But I would agree, some of these terminologies in our culture, they were transformed by public use is like a curse, like the term mental retardation or mental handicap and so on. So they are really linked negatively in people's minds. So they will try their best to prove that the child does not have it.
Well, you support the process or the suggestion of changing the name. I think if you change the name into like what is done in Egypt, I think, or in some countries, other countries, so the arrangement of electrical activity. This is really not a name; it is a definition of the problem or of the disease. And the problem is that not the term is what is which is the stigma. If you name it any name, even a brilliant name or a good name, and the stigma there when this patient will have seizures, will have falling down, will have trauma, will have drugs to be taken, will have some sort of social incompatibility, say. So I think for myself that the name will not change. As you said now, you try to discuss the problem with the patient's family and tell them that the process is some sort of change in electricity and some sort of unusual but as acceptable. But later on they will ask you, do you mean that it is sara'?
Mm-hmm.
That it is epilepsy? And you have to say yes. I mean, it will be taken as sara' or as epilepsy, whether you change this name or not. But if you put the name and you keep this name as sara' or as epilepsy, I think it may be better for the public orientation. Because if you tell the family that she's some sort of derangement of electricity, they will accept it and they will not seek for a further advice. Because the problem of diagnosing epilepsy is very complex, and there are a lot of people, say 30%, 40%, even 50% in our culture, who are diagnosed as epileptic. They are really not epileptic. Some sort of other problems, psychiatric or psychological, or the differential diagnosis of epilepsy. Anyhow, this problem is now being discussed. Even there is a task force in our region of International League Against Epilepsy to discuss this problem. A second question is that, do you think that the positive attitude towards epilepsy from people who claim that they have a positive attitude, like myself, I claim that I have a positive. I ask you, do you have a positive attitude? I think you will tell me yes. Do we really saying the truth about this?
Yeah, I think,
or it is only just just to say something useful?
Yeah, good point. Let me just have a small follow-up on the first question.
Yeah.
I think at the end of any interview with the parents, what I would do is I would direct them to an kind of online 50 question answer document in Arabic. And I tell them, well, this is your homework. Because in whatever time during your busy clinic, you may not be able really to address their concerns and all their questions adequately, especially when you are dealing with a diagnosis like epilepsy. So with the years, I found really easy and helpful to have this document that I posted on Google. So I tell them, you go search, write, because many of these people, they will go into what we call it in Arabic muntadayat, or the kind of special groups that has all kinds of bogus information. So I tell them, go download this booklet, which is free PDF. It has 50 question answer format in Arabic. It kind of covers all the educational aspects, and that I found that really helpful. It's easier than giving pamphlets or flyers that finish and people use them, write on them in the clinic, and they toss them away. Your second question, I think it's very valid, and this is one of the limitations of questionnaire studies, because you ask the person, he answers to you. You are not verifying 100% that what they're saying is what they're really believing or practicing. And we try to get away around this problem by asking or tackling a given misconception or problem by using different questions from different angles. But it is indeed a limitation of these studies. I agree.
Okay. Well, one question from Mareem Al-Ayubi. A comment and the question: public education is also affect the use of anti-epileptic medication, as I faced parents who refused medication and patient came to ER with status epilepticus. How should we lead them to use the drugs? Fair question.
Yeah, and I think this is more so if you're using controlled medications. So I try my best, at least when we start with medications, is not to use controlled drugs that are used by special prescription and a special procedure. That's number one. Number two, in most situations, we try our best not to discuss medications from the first interview. Some of these patients, there is no rush into that decision until they kind of absorb. But at the end, you tell them about the drug, you give them the name. Now information is at their fingertips. They will go Google it. They will know everything about it. Sometimes they know about a piece of information about a given treatment more than us. They are sometimes more updated. But I think the solution to this problem in general is effective communication. So if you effectively communicate with them, I think in general you overcome this problem.
Okay. Another comment and question from other audience. Many thanks all for organizing this webinar and for such an excellent presentation. Thanks for Professor Jan. Did you notice any improvement in the level of community awareness about epilepsy over time?
Yeah, and I think some of the studies that I presented shows that that's the case. But again, I must say, there are things that are not said. And this is similar to many of the kind of discrimination or racism in the world. People say something and then they do something else. So they say, well, we like this, we are okay with this. But when somebody with epilepsy come and ask for their daughter's trying to engage, they say no or find other reasons. So, but I think in general, I think there is some evidence that it is indeed improving.
Oh, good. Some thanks come to you from Professor Raida Al-Baradi. That's special for you, not for us. Well, I have just one question, maybe the last, if no other questions from audience. Do you prefer when there is some sort of engagement or marriage for an epileptic girl or epileptic boy, I mean epileptic girl in the first, to tell the future partner about the truth, about epilepsy in details, or to hide this and tell him in some way of, for graduation, for public, for social, gain?
And actually, there has been some situations where I was asked for advice. And I remember one young Yemeni girl who wanted to marry her cousin. And then I saw her when she was 13 or 14, and then they came for follow-up. And then she came one day with me with this young man that wanted to marry her. And then she wanted him to hear from me, her treating physician, about her condition and the outlook and the risks of treatments and the future of epilepsy in the offsprings and so on. And I thought that was very brilliant of her. I think this decision is up to the person, so you cannot enforce it. But of course, if they ask for our advice, I think hiding such information is a kind of a recipe for a disaster in these relationships. So it's always best if it is clear and in the open. Maybe I understand some people who want to hide things that may be benign or go away with age, or but in general, I think declaration is the way to go.
Oh, to let him know is better, in your opinion.
If he really loves her, he will stick with her.
Yeah. One question from other audience. Can doctors help in creating social community group? We can participate and do better than others in spreading knowledge.
I think doctors can be used as kind of advisors or counselors, but I think it will be difficult for doctors to be engaged in such, and many governments, and they don't like people to create social groups without kind of control and surveillance. As I said, I utilize the online system to educate the parents. I think the idea of social groups is excellent one for specific disorders. So if there is, but making a social group for epilepsy, which is kind of very big and very vast, with varying problems and varying degrees of disabilities, is kind of may not be practical.
Okay. Thank you very much, Dr. Mohammed. I think this was the last question. Thank you for this nice presentation and for choosing this very important and very social event to discuss. Thank you.
The organizers and all attendees. Thank you very much.
Thank you very much. Thank you. Well, we may go now to introduce Professor Johanna Kikilem from South Africa. She is a retired scientist, psychology, PhD in psychology. She made a lot of papers in field of epilepsy in her country. And this lecture will be not very far from the first lecture, epilepsy stigma and the patient perspectives in resource limited countries and settings. Well, Dr. Johanna.
Good evening, and thanks for the introduction and thanks for the invitation to participate in this seminar. Let me share the screen. Is the screen there? Can you see?
Not just yet.
Is it fine?
Yes, we can see it now.
All right. Thanks for the insights from the previous speaker. I really enjoyed his presentation. It's actually similar, but I actually chose to speak differently, focusing on the patient perspective in terms of shame and resistance. But first, I would like to thank all my participants in the study for their valuable contributions to this research project, as well as my promoter, Professor Leslie Swartz, for his support throughout my doctoral and postdoctoral work. In my introduction, I'm going to refer to my work, my doctoral work that I did on epilepsy. So my qualitative study was on perspective and subjective experiences of people with epilepsy and their carers. And the study sought to gain an understanding of these aspects from people who have epilepsy and their carers. And by carers, I mean family members, and then folk carers like traditional healers, medical doctors, as well as home-based carers. So the aim of the study was to explore perspectives and subjective experiences. And the objectives were to describe and analyze these aspects and to provide information that can be used to guide policy, research, and practice. Now, to gain an in-depth understanding of these perspectives, I used a Kleinman's explanatory models framework and his theoretical framework I've given examples of the kind of questions that I asked for my study, even though Kleinman talked about, can you hear me properly?
Yes, we
Hello,
can.
you can hear. All right. Even when Kleinman talked about the problem, in this first question, I said, what do you call this illness? I didn't want to say a problem because it's as if one is stigmatizing. And then what do you think has caused this illness? Why do you think this illness started when it did? What do you think the sickness does to you? How does it work? How severe is the sickness? Will it have a short or a long course? What kind of treatment do you think you should receive for this illness? What are the most results you hope to get from this treatment? And what are the chief problems that this sickness has caused? And what do you fear most about the sickness? Now, this type of ethnographic questions actually allow people to talk about their illness more freely, because they pose, the questions are posed directly to them to talk about their illness and how it affects them. My research design was a qualitative exploratory research design, and I did this study in an urban township in Cape Town. In this urban township, most people are Xhosa speaking. There are, of course, other languages that are spoken in this particular setting. Of course, it's one of the settings that has had a lot of marks from the politics of the past colonialism. So the population is still marginalized despite being in the democratic state. The sample included, now what I'm going to talk about tonight is really part of the findings of this larger project. So I'm just giving now just a brief overview of the whole project as it was. The sample had patients with epilepsy, 12, and then 12 family members referred to as popular carers, 18 health home-based carers, 9 traditional healers, and 10 general practitioners. So I used a purposive and snowball sampling method. The study was approved by the local ethics committees in Cape Town. I, of course, conducted individual interviews and focus group discussions in the natural settings of participants in their homes, and the duration was from 45 to 90 minutes. I constructed a semi-structured interview guide and a focus group guide in English, because I'm not Xhosa speaking, but I'm conversant in the language. So these instruments were translated from English into isiXhosa by a Xhosa language practitioner. All interviews and focus group discussions were audio recorded and transcribed by a Xhosa speaking transcriber. And of course, I used Brown and Clark 2006 thematic approach for analysis of all the data. Why I used Kleinman's explanatory model is that these questions enable patients, people with epilepsy, to tell their stories about their illness, experience, and suffering. And because I was also interviewing carers, it also enabled the carers to retell the stories about how they experience the illness of those that they care for, because I was now asking carers about how they care for the person with epilepsy who is under their care. So for Kleinman, every illness is not a set of pathologies, but a personal story. So in epilepsy per se, these stories are often told by others, because a person with epilepsy will tell you that I did not see that I had a fit. People told me that I fell. I didn't know why I fell at the time that and I don't even know what caused that fall. So you find that their stories, or when we take history, these stories are told by others and may, or quite often, give different interpretations and meanings. So for the purpose of today's presentation, I will therefore focus on 4 stories of women who had epilepsy, who took part in my project, to share their experiences and perspectives on epilepsy. I will first start with the story of Kulu. And these are the stories about shame. The previous speaker talked about stigma. So I preferred to talk about shame because it's one of the issues that has never been investigated or that has received little attention as far as literature on epilepsy is concerned. So Kulu, aged 27 years, is also on ARVs. I'm talking in the present tense because I'm talking about somebody who has epilepsy. And she lives with a 12-year-old daughter. Now, on interviewing Kulu, she shared with me that she experiences shame from having epilepsy. In fact, reading from her verbatim account, she says, when this problem arrives, the problem, now when she says the problem, she refers to epilepsy or a seizure attack. When this problem arrives, I notice one thing. I wake up wet in shock because I have urinated on myself. I just realized there is an action that happened. My child faces difficulties with this thing, meaning with this thing of urinating and this thing, this illness of having epilepsy. And she becomes embarrassed because we sleep in the same bed. And she now talks about how she had a relationship with a boyfriend and how her boyfriend stopped to have this relationship because he found that she wet the bed when they were together. And now having AIDS, this boyfriend started calling her names, saying you've got 4 names. Now in South Africa, they use the label 4 names to refer to AIDS. So they say you've got 4 names, then you know a person has AIDS. So now she says, I decided to stop and focus on my life because because of the shame that I experience from having this illness and from having any other relationship. Now, in terms of perspectives on her illness, she says this illness is a problem. She refers to epilepsy as a problem because it causes her to urinate and causes her daughter to be ashamed and embarrassed. Now, the second one was Bizana, who is aged 53 years, and she perceives epilepsy or explains epilepsy as a wrong illness, meaning that it's a horrible illness. Now, in isiXhosa, they would say, epilepsy is wrong, le illness. So when a person says it's wrong, you may think that she says it's wrong is incorrect, but in fact, they mean it's a horrible illness. She says it made her to leave school and it causes her to lose weight. It has also affected her role as a mother. She says that this illness has caused her to be forgetful. And because of being forgetful, she tends to blame others. And she often feels embarrassed for accusing others and experiencing feelings of shame thereafter. Because now when you accuse people that they have stolen something, when you have put something elsewhere, and later on you find that you get that thing that you were looking for. So you become embarrassed and shameful about your actions. So she also has financial challenges because she does not receive a disability grant, she does not work. And then this grant, for a person to get it, it depends on the motivation from medical doctors. Now, these were the stories about shame. Now, one reflection about this issue of shame, it's that the stories of these 2 women with epilepsy show feelings of worthlessness, of guilt and anger. And these, of course, can affect their emotional status and can predispose them to poorer health outcomes as well as health outcomes of those who care for them. Remember, the Bizana is a mother, and Kulu is also a young mother having a 12-year-old. Now, they also can be seriously affected by these experiences of shame as carers of these women. Shame also strikes the core of a person's identity. Remember, Bizana said she loses weight because of this illness. And now in African culture, sometimes when a woman is thin, people might think that, oh, she's not well fed, she's not well cared for. So it's something. Identity is very important, and if you lose weight, you have changed. You have become someone else. So according to Lee et al., they say shame strikes the core of a person's identity and forces the individual to contemplate the possibility of a defective, unworthy, or damaged self. So you find that you are not worthy to be living. Hence, Kulu even said that sometimes I even wish I could die because of feelings of shame and embarrassment. Reading again on this issue of shame, Dolezal and Lyons 2017 states that shame remains under-theorized and unacknowledged in the context of health and medicine. So one may therefore wonder what the impact of shame on women with epilepsy is in the context of global this Corona-19 pandemic. So this was really just a food for thought when I was preparing this presentation. Now, very interestingly, I had two women who talked about something that I did not anticipate. And they talked about issues of resistance. Now, this was Manzuza, a 43-year-old who had been married and had been divorced due to having epilepsy. And she highlights in her story issues of spousal abuse and marital and poor marital relationships. She shows that she has personal strategies that she uses to resist discrimination from taking steps to fight her abusive marital relationship problems. Now, in her story, she actually said that she went, I will just read the excerpt from her transcript. I went to social workers because my husband, left home. And because he liked coming with this woman here, the one he's living with now, that he has married. This is bringing me stress. But I went to the social worker, and that social worker did not listen to this. She spoke with him for a long time, but I did not know what they talked about. I went again to the social worker, but she didn't say that she didn't tell her that they discussed this and that with her husband. But what the social worker said, she said to her sister, what I advise you is that you must have a plan or think of a way to get yourself another place to live and just to get out of this house. And Bizana says, Manzuza says, I asked her, I said, I am not crazy in my head. I will never do that. My house is close to the clinic, it's close to the police station, it's close to the shopping center. So I won't go. I will never leave my house. You would rather deal with this men's problem, not the steps that I have taken. Now for Ndombi, this was very interesting. A very young girl who left school because of being teased. She said she fought this, her being bullied by her peers. She beat them. She was actually even proud when she talked about it. She said, I beat them. I wanted to show them that this illness can affect anyone, so they cannot tease me. They don't have the right to tease me. So I retaliated against being bullied by my peers. Now, these were the issues about resistance. Now, from listening to these stories, it was interesting to realize the importance of asking questions that explores personal strategies that people with epilepsy have. Because sometimes we look at people with epilepsy and we think about the illness and its psychosocial challenges. We never think about the strengths that people with epilepsy have that we can explore and enhance with the different interventions that we do. So when I read literature about the asset-based approach, I learned one thing, that no one is born without gifts and talents. Even people with epilepsy, despite the challenges that they face, are born with gifts and talents. So these must be explored as to why, what can they do to control their condition. About the asset-based approach, this McLean et al. States that, McLean et al., you say my internet connection is unstable. Okay, it's fine now. I'm going back to where I was stating about McMillan et al. About the asset-based approach. They say, with the recognition that the current models of delivery of public services are no longer effective in addressing causes of ill health and poor quality of life, an asset-based approach which focuses on what keeps us healthy rather than what makes us ill. So perhaps in trying to deal with issues of stigma and issues of shame, what we need to be asking is what keeps people with epilepsy healthy, rather than what is actually being done, or how do they feel about stigma, how do they experience stigma, how do they experience shame. Maybe we need to move from that. So these were some of the reflective questions that I was asking myself as I was preparing this presentation. In sum, I've shared stories of the 4 women with epilepsy that highlighted shame and resistance as issues for consideration in epilepsy research among women with epilepsy. Thank you for your attention.
Thank you very much, Dr. Johanna, for this nice presentation. Really, you go through the patient point of view towards the problem, which is a very good point, really. Maybe sometimes missed by physicians. Well, we can now open the question and answers. If anyone wants to ask about the subject of patient perspectives and stigma. Well, I may ask you, Professor, about the resource limitation and resource unlimitation. I mean, if there is a resource unlimited setting, no limitation, would this affect the patient perspectives? To myself, I think the problem is the same, whether here or there. But can you declare or define or show any changes from this point? Yes.
Okay, thank you very much, Prof.
Yes.
In the setting in which I did the study,
Yeah.
People with epilepsy, there are available epilepsy resources. They are available, but they are not accessible. people with epilepsy, most of them that I interviewed were not employed. They suffer financial difficulties and challenges. Some of them have come from the Eastern Cape and have relocated to this urban township in search for support services. But you find that they are really struggling because of their limited personal resources, financial resources. They can't access appropriate medical care. It's not only about limited resources, also the language barriers. How does a person who is not literate able to explain the questions that are being asked on clinical follow-up? I mean, I did observations in my project where I visited how the clinic in which these patients were receiving their epilepsy treatment. And I was struck by the way the health system is actually structured. Only 3 questions were asked that I observed. Did you take your medication, your seizure medication? Did you have a seizure? If the patient says, yes, I had a seizure, then it will be how often, when was it, when, how long was it? And then from there, nothing, no assessment, no counseling, and then the prescription is given to the patient goes home. I had one patient with epilepsy who said that I drink these tablets. The patient was on phenytoin. I take this medication regularly, as I'm being told, but they make me dizzy. He said, Mama, I'm not an alcoholic. I don't drink alcohol. But after taking this pill, I feel as if I'm drunk. So I have stopped to take it. I rather go to church and get a religious leader to pray for me, and I feel much better. So patients do not receive counseling. And why? Is because of the routine task system where patients are not seen as humans, but just with the questions, and then they must go, because healthcare professionals are looking at the time, the number of patients that have to be seen, of course, taking into consideration the shortage of staff and the shortage of doctors or trained nurses in epilepsy treatment and care. So I could not share my whole project for this presentation, but I did observations. I looked at the pamphlets, the kind of information that is given for people with epilepsy who don't even understand their illness, but the language that is used is actually confusing. I mean, I had a poster where I asked the patients to tell me what they understand about the poster message. And the poster message was, take the tablet, you must make sure that you take the tablet. And the patient said to me, how do I take a tablet when I don't even know when I will fit? So it's the message was really not quite understandable. So these are some of the kind of health system factors that affect the understanding of epilepsy and possibly perpetuate the stigma towards people with epilepsy. So maybe I can stop there so that people can ask questions, but I've just looked at what the poster said. The poster said, take control of your epilepsy. And he said, say no to seizures. And then he said, say yes to taking my medication. Now, on asking, the patients with epilepsy, they said, the other one said, how will I say no to seizures when I'm actually having a fit? So I was also, I did not know what to say, but now what I'm trying to say is that the way we design the information leaflets for people with epilepsy needs to be looked at, needs to be evaluated. I will stop there in the meantime so that I can take some questions.
Thank you very much for this nice and efficient answer. And your lecture took us to the point of the psychological point of view of the patient. We should take care of this point. As you know, the psychological aspect or psychological state of the patient plays a very important role in treating epilepsy and in in the welfare of the patient while taking therapy. I don't know if any other question from audience. Still no question. Do you believe that the same problems in your culture is the same? I mean, in other cultures the same, or do you believe that there are variations here and there? I see myself the same problems in Europe, in South Africa, in South Asia, and I don't know. Can you highlight this point?
Yeah, thank you very much. I think the issues about epilepsy throughout Africa could be the same. I mean, when we talk about stigma, you look at the names that refer to epilepsy. There are different names, there are metaphors that are used. In my country, I mean, Swars talked about, you know, the grand mal epilepsy. Then patients look at the mal at the end, and they say, in an African setting, they say, oh, mal is mad. So it's like, oh, LS mal, this person is mad. So they look at those kind of things. And then the names that explain epilepsy also are also stigmatizing in a sense, especially even illness metaphors. For example, in the study that I conducted amongst home-based carers, they talked about, they were describing the symptoms of epilepsy. And they say, when a person has a seizure attack, this person will look like a chicken that is being plucked. Now, when they described the plucking of the chicken, the process through which the chicken is being plucked before you actually kill it, on the other hand, I thought it's stigma. On the other hand, I just thought, well, there are African metaphors that may actually help a person to understand, but probably sometimes we look at stigma and we just think that everything is stigma, but we don't actually say, hang on, but this might actually help a person to understand, because now they understand how to pluck the chicken before they kill it. So maybe that can actually help the medical professional to understand what the actions that people do when a person has a seizure attack. So there are also a lot of issues around marriage and driving, which perpetuate stigma. And then I normally watch Africa Magic, this series of dramas that are on our TVs, especially African Magic. They portray epilepsy as an illness where somebody cannot get married. So the stigma is still being portrayed via television stories. So I think we also need to look at the kind of stories that are being portrayed over the television, just to reduce the stigma against epilepsy. But also looking at literature on epilepsy, from the medical or Western trained language, epilepsy is referred to as it's a neurological condition, it's a condition. Then next time it's a disorder, it's a brain disorder. Then people with epilepsy, we refer to them as epileptics. So now one asks yourself, who is actually stigmatizing? Is it the community? Is it also the medical or Western trained professionals? Because if we say we've got so many epileptics, we are not referring to people with epilepsy as people. They're epileptics. So why can't we look at the language that we use? Is it, and people are talking about an illness. They're not talking about a disorder. So is these words that are being used also perpetuating this stigma that we are talking about when we engage with people with epilepsy? So but otherwise, the issues around limited resources, around lack of medical, well-trained healthcare professionals for treatment of epilepsy, it's really, I think the situation is similar even in the other African areas. Yeah.
Thank you very much. I think that is the last question. Thank you very much, Professor Jahan, for this nice presentation and nice lecture. And thanks also to Dr. Muhammad for his nice presentation. And thanks also for Ms. Shannon for her efforts. And welcome to see you later on in the monthly webinars of the International League Against Epilepsy. Thank you very much.
Thank you. Thank you for the invitation.